This week on the Back Table Podcast.
There's so many hospitals around me that have no OBGYN care at all. It's literally a Band-Aid dispensing center. It's an ER. That's it. And a 20-bed, basically sniff unit for elderly. And they keep coming in, with obstetrical complaints. And they don't even have an ultrasound tech to, scan these patients, to even get a heartbeat or anything. So anyway, point being, what is the reward? The reward is, if I was in Lexington, I would just be one of many OBGYNs taking care of patients. And I could be replaced by X, Y, and Z doctor, whoever. It doesn't matter, right? Here, I have such a big impact. Because if it's not me, then who? I'm one of 4 doctors who cover this hospital. That's it.
Hello, everyone, and welcome to the Back Table OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on backtable.com. My name is Mark Hoffman, and I'll be your host for today's episode, and we have a guest from relatively close to where I am at the University of Kentucky. I've got Dr. Jessica Branham, who is an OBGYN practicing in Prestonsburg, Kentucky. How are you doing, Dr. Branham?
Doing very well, thank you.
Thanks for being here. This is an episode I'm super excited about because I grew up in Kentucky. I grew up in Lexington, which is a pretty medium-sized city. I don't really know how else to describe it, but my experience in Kentucky was growing up in Lexington, and if we ever traveled, it was outside of the state primarily. It wasn't until I came back to Lexington for medical school that I met a lot of people from outside of Lexington, and it wasn't until I came back to the University of Kentucky for my job that I got to spend any time actually working outside of Lexington, specifically in Eastern Kentucky. And my experience there, and I don't want to sound too ridiculous when I say the word transformative, but my time in Eastern Kentucky was just that. It changed how I thought about medicine. It changed how I thought about healthcare access. And it was important to me to have somebody on our show who could talk about that. And Jessica, I'm thrilled you're here. And let's get started. Tell the audience about you, where you're from, where you trained, and then how you got to end up where you are now in Prestonsburg, and also maybe explain to people where Prestonsburg, Kentucky is.
I'm currently practicing at the hospital where I was actually born.
Oh, no kidding.
I always make the joke that I didn't get very far in life. Prestonsburg is the county seat of the county that I practice at. And so naturally, the topic is rural America, right? And rural Appalachia. So this is a rural area, whereas Lexington and Fayette County is like the same thing. Where I am, there's a town and you grow up in the road that's down the road from the town, and no one knows where any of this is because it's in the middle of nowhere. And for all my friends on the East Coast and the West Coast, I'm in the flyover land of nowhere.
We're all technically in the flyover, but...
Right, you are too, but...
No, for sure.
I'm in that green zone. On the Google Earth map, I'm the green.
Right, there's nothing there.
But this is home. No matter where I go, this will always be near and dear to my heart. And growing up, I didn't think I would live here. As an adult, growing up, I swore I was going to leave here and never come back. And then I ate those words, I guess.
We all do that. I did the same thing.
Yep.
So
yep.
I live not too far from where I grew up. So you grew up in what county?
Floyd County.
Floyd County.
Right. And I like how you said what county, because as you may know or not know, in Kentucky in general, we refer to where we're from as the county rather than the town.
Yeah, that was something, I'm from Lexington as a city. And so all of my med school friends from outside of Lexington or Louisville would tell you what county they were from. And you'd say, oh, no, well, what city? Like, no, there's not really a city. It's just a road.
It's not really a city, right? It's like
that my house is off of that is in a county. Yeah,
right.
That was totally different.
And the point of me saying all this is because I did train in Philadelphia, and living in the mid-Atlantic area where it was very large urban area, no one had any idea where any of these places were or where they were on the map, or where Kentucky and Tennessee. And my program director, God love his heart, he would make fun of my accent on a daily basis and be like, I'm Jessica Branham, and I'm from Kentucky, South Carolina. And I'm like, Dr. Jack, it's not the same. It's not the same.
No, I mean, I had that experience just going up to the University of Michigan for college, and people thought, it's a 5-hour drive. It's like, I've done it there back in the day.
Yeah.
Not a lot of folks have a lot of experience in this part of the country. And so how was that transition? So you did med school at the University of Pikeville.
Right.
And then went to Philadelphia. How was that transition for you? Is that the biggest city you'd ever lived in?
Yes. So I had lived in Lexington for undergrad. So I went to University of Kentucky.
Okay, you went to UK.
Yeah, for my undergraduate. And then I came back home for medical school. And I really wanted to come back home for medical school. My family's all here, and I knew that would be a really challenging and stressful time of my life. As it was, I was kind of feeling lonely in Lexington. It was only 2 hours away, but I was like, well, I'd like to be home. And, my parents would bring me food and do my laundry when I was in medical school. That was so nice. So Pikeville was home, and I was missing home, which was strange because, again, I think of Lexington as home now, too, after living in another state. But anyway, Philadelphia was a whole nother culture, obviously. People are hard to get to know, but once you get to know them, you'll make a friend for life. So they're very honest. They're no BS kind of personality, for better or worse. I love Philadelphia. I miss it, actually. My husband thinks I'm crazy for saying.
Is he from the same part of?
He's from Letcher County, so he is from Whitesburg, which is why we went to Whitesburg the first year and a half I was in practice. That didn't work out too well.
And how far is Whitesburg from Prestonsburg?
So, 60, 80-ish miles southeast from where I am now. Philadelphia was a wonderful experience for me, just getting to take care of so much diversity and, of course, a large population of, volume people and different types of people. And it was a great experience just as a physician trying to learn. I think it's always great to have volume and diversity during training, right?
For sure. I mean, and also training a place that's different from where you went to med school and working. It's different from where you trained. I mean, I feel like I've been able to take pieces of every place I've gone to try to make, wherever I end up better, right?
Yeah. The one thing that I'll never forget, I was one day standing there on labor and delivery, and I don't even remember specifically what the situation was, but we had this kind of rare, I want to say it was maybe a fetal cardiac issue, or I don't know if it was Epstein's anomaly, or it was something, and the patient, we shipped her to CHOP, Children's Hospital of Pennsylvania, and shipped her 30 minutes. So I was like, let's put you in the ambulance and take you down the road 30 minutes away to CHOP, which is this world-renowned hospital that can do, all of these amazing things and fetal surgery for your baby. And I just remember standing there thinking, and I actually looked at one of the nurses and I said, you people have no idea how fortunate you are. And she was like, what?
And that was my experience. And so when I did med school here in Lexington at the University of Kentucky, and then did residency at the University of Chicago, and that's in the south side of Chicago.
Yeah.
An area with significant urban poverty. I had spent time in New York City after college working in nonprofits and saw a lot of urban poverty there. But what I hadn't ever seen before was rural poverty and issues in healthcare and access in rural areas. And so when I came back to the University of Kentucky, I'm a minimally invasive GYN surgery by trade, and building a practice that's brand new, you have a little more free time and are looking for ways to sort of justify your salary and moonlight a little bit. And University of Kentucky ran a practice in Hazard, Kentucky, in Perry County, Kentucky, the town with one of the lowest life expectancies for women in the country. And so I would stay in the Hampton Inn and Suites for the weekend, and right up the road from the Hazard ARH, which is Appalachian Regional Hospital, which is a network that you're currently working in, correct? ARH?
Correct.
The time that I spent there, both in clinic and in labor delivery, when I was still doing obstetrics and doing surgery down there, it was eye-opening, to say the least. What we were able to do for folks there, we were limited, right? I mean, in some ways, it felt like we were working on the space station because, I need this thing. And they're like, they look at you like, what? There's no way I can get that thing for you here where we are.
We don't have that.
Yeah, just forget it.
Well, that's what I made that realization because I did medical school here. Majority of my clinical rotations, with a few exceptions, I did gyne-onc at ETSU, and I did MFM. I did some out rotations. I went to Columbus and did some OB for electives. But for my core, I did that here in all the hospitals in Eastern Kentucky. At the time, I thought, am I getting enough? Would I have been better served if I would have went to University of Kentucky or University of Louisville for my medical school? You kind of have I'm at a DO school. Am I good enough? I'm doing these rotations. Am I good enough? Residency, I realized actually I got a far better experience because it was just me and the attending one-on-one. I got to be the one to suture all of the little incisions and the laparoscopic surgeries. And my attending let me put in all the PICC lines. I mean, he just stand there and be like, go for it. Because he knew I was like gun-ho about anything I could get my hands on. And it was amazing.
Help is not easy to find down there. I mean, when I would do surgery, there'd be, a med student there.
Yeah.
And like that would be the assistance that I had for a case. And I think, so UK is an MD school. And what I didn't understand about Pikeville Med School, and I don't know if that's the case with all osteopathic schools, but the rotations are not always at the medical school. Basically, all the rotations are at UK Hospital, at least they were when I was there.
Yeah.
I was down in Hazard and this kid shows up and he's like, hey, how are you? I'm so-and-so. And
hey.
I was wondering if I could watch this case with you. And I was like, okay, oh, sure. Who are you?
Who are you?
He's like, oh, I'm the OBGYN third-year medical student rotating down here. I was like, down here? Like, who?
Yeah.
There's no curriculum down here. I was a third-year clerkship director at UK, so it was all so structured. But this student had access to the OBGYNs that were there. He got to basically be part of the care team in a way that I certainly was not at the University of Kentucky. It was very different, and it was unusual for me, not better or worse. It was just like,
it's different.
It's just totally different. Like you said, then you go somewhere else, like, oh, wait, you probably had less autonomy in Philadelphia at times than you did back home.
Well, like I did a lot of our rotations, like we did gyne at Temple, and there was, fellows, and they went to Cooper for Urogyn, and there was a Urogyn fellow, and so the Urogyn fellow's like, go around, hold this, and like he was the one getting all the procedures, and I'm standing behind him like,
holding a retractor or something.
Right. And I'm like, what? Like, I usually do this procedure. Like, oh, yeah, he's the fellow. And the same thing with medical school. So we call PCOM, but the Philadelphia College of Osteopathic Medicine, their students would come over and to rotate with us. We would have University of Pennsylvania medical students that would come over and rotate at my hospital. So I would have a Penn student and I would have a PCOM student. And I'll never forget one time I asked a question. It was like my chief year. I was asking a question and I was pimping the students, and there was a girl, a female and a male, and the female was from UPenn and the male was for PCOM. And I asked the question, and the female student from Penn got the question correctly. And she, very smart, did great. And I was like, yeah, that's it. And I looked at him, I was like, what about you? And he was like, brr. And then later after she walked off, he was like, she's from Penn. And I went, I reckon the books read the same direction at Penn as they read up there at City Avenue. Like, what are you doing, buddy?
You got to step it up. You got making us look bad.
But I was like, no, like that's not an excuse. What's that got to do with it? You have the ability to access the same information, read the same textbook.
But you strike me as a very self-motivated person. I have plenty of colleagues who went to osteopathic medical schools, and this show is new. We've already had some on the show, and these people that just blow me away with all the things they've done in their lives. And the difference, it seems to me, that with osteopathic schools, the curriculums are not the same, and so you have to be a little more self-motivated at times. You have a lot of folks coming to DO schools that have like, I've had to do it all myself. I'm not impressed by any of this, and it's incredible. It's a different model, but one that I think we have plenty of colleagues who've done amazing things from both tracks. But I want to spend time really talking about your practice, because what I want our listeners to understand is that in America in 2022, there are places where patients don't have access to healthcare in the way that we do, in the way we think about in cities. Patients don't have ready access to specialists. They don't have access sometimes to hospitals that have obstetrics units. When I would go down there and tell folks, hey, you need this procedure, it can't be done here, just come up to Lexington. And they would look at me like I was crazy. And I said, no, it's like 2 hours away. I drove down here this morning. I'm driving back this afternoon. But a patient's husband had taken off work and they only have the one truck, and they both took off work to come to her appointment because she can't see very well to drive. And so for them to get to Lexington was another day off work for both of them, and $50 worth of gas each way in their old truck. That's just for the consult plus the pre-op plus the surgery. I mean, to get these folks the care they needed was like asking them to move a mountain. And it was. I mean, it was a huge lift. And just come to Lexington to them was like, many of us think about going to Manhattan. To them, it was just easier just to stay home and deal with it. And it really shaped how I thought about how we care for patients, especially in these environments, because like you said, we read books, we go to school, we take tests, same answers everywhere. But then actually getting these patients to the right place, to the right doctor, and to get them the care they need, the answers that we're looking for are not always on the page, and you got to figure it out.
So your experience in Hazard is very, I think, representative to my day-to-day. My day-to-day life involves trying to figure out where are the boundaries of my limitations and at what point am I not comfortable and what point I am comfortable with doing things because this patient doesn't have the resources or the socioeconomic resources to get somewhere where they may be better served. You're a minimal invasive surgeon a specialist. And there are times when I have a patient that will have a huge fibroid, or just the other day saw one that was a little bit fluffier in the panties that I like to operate on with my straight sticks and my not tertiary care center. And I say to her, I could open you up and I could put an incision that's about 10 centimeters across your belly and put you at risk for all these things, wound infection because she's diabetic or what have you.
These are the patients that stand to benefit the most from laparoscopic surgery, right? I mean, it's a huge deal for them.
And so sometimes these patients have the resources and they say, oh yeah, Lexington, I go shopping there all the time. So I have some patients that do have the resources and the ability to drive up to Lexington and get that laparoscopic or robotic hysterectomy that I may not feel comfortable doing here. But then I have some patients who use their last $5 to go a few miles down the road to make it to my clinic that day just to help me stop her from bleeding. And she just wants it out and she doesn't even know where Lexington, she's not sure she can make it that far, or she doesn't have a car to get there or the money to get there, or she's just terrified at driving in the big city. When people are intimidated, we're on these small roads, we're in a rural area, people are comfortable here, they grew up here, and even though the roads have changed over time, they've been here when those changes took place. Lexington seems like a world away from them. It's just completely
one-way streets and parking garages, and they're like, forget it. I'm not dealing with that.
Yeah,
because the UK is near downtown, right? Getting to Good Samaritan, where I work, or to Chandler Hospital, is confusing for those of us that live here. Let alone it's a massive health center. So to think about coming from a small town into that, it's important to think about it from the patient's perspective, right? So patient-centered care, we think about that. It means a whole world of difference when we're talking about patients who come from such a different environment than the ones that we're used to.
I was thinking about this podcast and I had to ask you, what exactly are you wanting me to talk about here? Because, I could see this going in many different directions. And I, of course, start preparing. Okay, I'm going to pull a committee opinion and I'm going to start, you want to know quotes of because I got those right here, when you talk about rural America and these are your sickest patients. That's the crazy part is we have the least resources, but we have the sickest patients. We are higher risk for even things like motor vehicle accidents, cerebrovascular events, suicide. It's in the committee opinion. You can just pull that up. Obesity, obviously cigarette smoking, low birth weight. We have a higher maternal mortality rate than any other, you mentioned that earlier. These patients are sick. Unintentional injury, self-harm, suicide. All of those things.
And they have to drive farther for care. And so the risk of car accidents, like you said, goes up.
Yeah. But also, I was looking at just cervical and breast cancer. We had the highest cervical and breast cancer rates in the nation. I was looking at 13, counties. No, it was 13 states. So Appalachia, 54 out of the 120 counties are considered Appalachian. And of course, out of those, Kentucky and West Virginia had the highest invasive cancer rates in all of Appalachia. So we're talking about rural for rural. We're talking about the worst of the worst.
To have that combination of the sickest patients in some of the least well-resourced hospitals, it puts a lot on the providers. I work at our transfer center, so I get phone calls from anywhere from orthopedic surgery to trauma. I'll do this a few shifts a month, but I hear every phone call that comes through when I'm there for every service from all over the state. It changed my perspective, and it changed how I take these calls, understanding the challenges these docs out in the community. I mean, they're trying to take care of these incredibly sick patients with none of the resources that we have at a big institution, not multiple ICUs and, traumatologists and all these things. They're out there on their own. Let's start talking about your day-to-day. How many people in your practice? How many days in clinic, OR, L&D coverage? What does your week look like? Because my guess is it's very different than my week.
So this is kind of a strange time in my practice. Typically, I would say I see anywhere between 25 to 30 patients at a clinic day. So I don't think that's a high, crazy volume, but I don't know, that's a normal amount. But my acuity is probably quite high sometimes. So I have one surgery day a week, and sometimes I'm full and busy, and those other days I just have a few cases and that's it, and I'm done. I take Mondays off now, which might sound strange, but if I don't, because I am on call at least once, twice a week, 8 to 10 call days a month, because I'm one of 4 OBGYNs that covers labor and delivery, well, all OBGYN, at the hospital. And that just changed recently because I was 1 in 3 up until very recently, and then we had another one join, our call pool, so which is nice. So 1 in 4. So instead of having 10 call days a month, I've kind of dropped down 8, yay, 1 week in a month, usually. So when I'm on call, that's probably what's so different for me than you. I don't know if you do call or not, but when I'm on call, I take it from home, so I'm not in-house. But some nights, get a few calls a night, and it's not bad. And then there's other nights I'm literally there all night or don't get any sleep. Sometimes I'm going in at 2 or 3 o'clock in the morning, calling you guys at UK and saying, hey, I have this 30-weeker with severe preeclampsia and, trying to get them out. The scariest part about my job is when I'm on call, I find it harder and harder to relax because I never know when that phone rings, if it's going to be something simple or if it's going to be like a disaster. And when I'm on call, I'm it. I am it. I don't have, I have great coworkers, partners, but our time, we don't have a lot of coverage. So when we're on, you're on. And when you're not obligated to go in or help. And sometimes you're not even in town because it's your weekend off. So sometimes, you just kind of got to manage it yourself.
I was pretty fresh out when I was going down there, and I don't do OB now, so I'm not doing in-house call. But when I was a fellow, we did a night a month. Mm-hmm. My OB boards list was great. I had like 26 patients. We didn't do a lot of OB in MIGS fellowship and coming out. I did a few calls a month here and there, but going down and working in ARH, you're it.
You're it.
Yeah, maybe the nurse may have been a traveler, been there about a week and a half.
Yeah.
Anesthesiologist, the other thing that I think a lot of people take for granted. I don't know how you guys have it. Do you guys have an in-house anesthesia provider?
No.
No.
So this is also, we don't do VBACs, right? We don't do VBACs. Not because we don't believe in VBACs. I love a good VBAC. When I first came to Highlands, I was doing VBACs. I did 2 in 1 week, and then I got called to the meeting, and they were like, what are you doing? Why are you VBACing these people? I'm like, well, she came at 8 centimeters. It'd be a sin to cut her. And like, yeah, well, anesthesia's kind of getting ticked off at you because they don't want to be there waiting for your patient to deliver. Now, these were multips, okay, who had a proven pelvis before, so I will say it wasn't crazy. I wasn't like VBAC and a prime who came in at 2 centimeters. They came in very active, and it went really quick, and it went well. But I get it. My partners were like, you're going to start this trend of something that we really can't offer. And I'm like, you're right. I just came from this place of where we offered VBACs, and now I'm here in this place where we can't really offer those because we don't have in-house anesthesia, and so we're asking our anesthesia peers to come in and be there all night, just to be there waiting.
And you have to think steps and steps and steps ahead.
Yeah.
And thinking about, okay, this patient is progressing slowly, but the tracing doesn't look great. I could sit and watch it, and if something goes bad at UK or University of Chicago, you just say, all right, let's go to the OR, and baby can be out in a couple of minutes. Calling anesthesia from home, you're getting somebody out of bed, getting in the car, getting dressed, coming to the hospital. And I don't care if they are down the road. It's still 20 minutes. And that's if you get them on the phone the first time. And there's a couple of times where calling the anesthesia doc, and I was like, they're not answering the phone. I'm like, what do you mean they're not answering the phone? We got to get this kid out. Yeah. So there was some moments where I was just like, I am on the moon right now. I am on the moon, and there's nobody who can help me. And it put some hair on my chest, that's for sure.
It's terrifying.
It was terrifying.
So I've gotten used to it, but there's times when I've talked to Dr. O'Brien, who's your MFM, and I feel like I have that guy on speed dial. I'll say to him, I'm an idiot for being here. He's like, no, you're doing good work. You're doing good work. I'm like, no, I'm an idiot. If we have a hemorrhage, I have to say, get this, get that, do this, do that. And, we don't have in-house IR. So, I am either throwing a Bakri be lynching, giving all the things, or I've got to do a hysterectomy by myself, or call in a general surgeon to come help me. I don't have gynonc to come in and their magical surgical ways to help me with that. What I find so frustrating in this, which may be silly, but sometimes you'll call to transfer a patient, and you always wonder what the person on the other end is perceiving you as, some chicken, or you're a coward, or you don't know what you're doing, you're at this podunk hospital. And if they've had no experience in working in these settings, They don't understand how proactive we have to be. And like you said, we can't just think 2 or 3 steps ahead. We have to think like 10, 20 steps ahead of all the things that could happen. And can we handle that? By the way, that thing may not even happen, right? Like most of the time it doesn't, right? Statistically, it's probably not going to happen. But if it does, and she's here, and it's just me, what am I going to do?
That's it. You have just said it. That is it right there. And that, this is why I wanted you to be on the show. That's why I wanted to talk to you, because I didn't understand what the work of a rural doctor was. Certainly a rural obstetrician gynecologist. My respect for you, Jessica, is through the roof. And I hope you never feel that when you call anybody. It takes so much brains and energy and heart and all the things to do what you do, where you do it. Your patients are so lucky that you're there. I cannot emphasize enough the respect that I have for you to do what you do. I don't know that I have the guts to do it, and I've done it, right? I mean, it was a lot, but I also gained such an appreciation for what you do and how you do it. I hate that you say that, because the other thing we can talk about is that a lot of these rural hospitals are losing obstetrical services, right? If you don't do a certain number of deliveries, it doesn't make money for a hospital. And so doctors like you are becoming less and less common. We're putting out more and more medical students, but the population's growing. Most of the population in this country's growth is urban, is in cities.
Yeah.
And most people who train will stay in those cities. And so the percent of docs going into rural communities to practice is lower. And that, to me, is a health crisis of its own. And so not only are the resources scarce, not only are the preventative resources scarce, leading to such a high rate of serious medical issues like you talked about before, lack of access to, routine care and pap smears, increased cervical cancer rates, all those things, and obesity and food deserts. Everything is harder where you are. And so to not have docs out there, to make it so now instead of them having to drive 30 minutes to go see you, now they're going to have to drive to Hazard, and now they're going to have to drive to Whitesburg, or now they're going to have to drive to Lexington.
Yeah.
And that, to me, is the scariest thing of all. I just want you to know what respect I have for you and how grateful I am for the work you're doing and why I wanted to bring you on, because I don't
Thank you.
think everyone understands the challenges, but we have to also be super, super, super patient. Again, when we take calls from docs, like when you call, hopefully I'm nice on the phone, but
yes,
it is so hard. It is so hard out there. And
well, thank you so much. And I appreciate that. And it's funny because in my, looking at stuff before we had this conversation, you totally hit the nail on the head there. 2008, 6.4% of OBGYNs practiced in a rural setting. 6.4. In 2010, 49% of the 3,143 U.S. counties lacked an OBGYN. So 49% of U.S. counties lacked an OBGYN. Although more women are entering both family practice and OBGYN as a specialty, the majority of them are women entering these fields are staying in urban areas. They're not going to rural areas. They have a lower percentage of entering after training. And that, of course, a lot of rural areas have 100% OBGYN care provided by family practitioners, not OBGYN at all. Like I said, the numbers are backing it up. It's not, we're not just making this up. It's not in our heads. It's going the wrong direction.
Well, the other stat I read about that was that family medicine, there was a family medicine doc who rotated with us in the call pool in Hazard. But in 1982, I read this, 44% of family medicine docs delivered babies. And that's down to, it was 6 years ago. The vast majority of family medicine docs are coming out not doing.
No, they're not. They're not trained.
Obstetrics. And so that was a huge part of the workforce in caring for and managing obstetrics patients in smaller communities. And now not only are fewer OBGYNs moving into the communities, we don't have the support of family medicine. And so it truly is becoming a care desert in that sense. I mean, that's happening in surgery. It's happening across the board in specialties. But for maternal care, it's hard to have regional centers and people come in labor. They show up and these babies are coming whether you're prepared for them or not.
You can't stabilize them. Like, that's the other scary thing. Just this morning, I don't know if you saw in the news, there was a school bus accident in Magoffin County, which is one of the bordering counties. And Magoffin County, by the way, has 0 OBGYNs. I am the OBGYN for basically Magoffin County. Okay. There's no hospital in Magoffin County. We have a couple of federally qualified healthcare clinics, But anyway, the school bus wrecked, and they were having to transport some of the children that were involved in that wreck, and I heard that 3 of them had to be airlifted out. I was having a conversation about this, and the other person, who wasn't a medical person, said, yeah, they had to fly them out, and oh my gosh, it's so scary. And I looked outside, and I was like, well, thank God the weather was good today.
Oh, gosh.
Because when I hear get them out,
Yeah.
it's a knee-jerk reaction for me. First thing that I do is I look at the sky. What's the weather? What's the weather? I drive to work. This is so crazy. Who does this? I drive to work and I'm like, oh, there's a lot of fog. I hope nothing happens. Like, that felt crazy. But I noticed this.
One of my shifts down there,
Yeah.
taking care of a very sick patient, and I was trying to get them up to Lexington.
Yeah, can't.
It was an ice storm. So I was stuck in the ICU with that patient for like 12 hours because the ambulances just weren't running. The ambulances just weren't running. And I'm going, wait, what do you mean? She has to stay here with me? I'm not an intensivist. I'm not an ICU doc. That was one of those moments. I mean, again, I've talked to you about a few of them, offline too, but that's one of those moments where you just,
yeah,
I'm the best they've got, whether I'm, whatever happens, better that I'm here than I guess nobody. But
it's humbling.
Yeah. I mean, I think, look up at the sky.
Yeah, I'm on my way to work. I was like, look at me. What's the weather today?
What a response, though.
When I get a phone call, that's always my first thought. When nurses call me on a patient that is a potential transport, I always look at the sky and think, okay, first thing, what's the weather? Are we going to fly? Are we going to get her in the ambulance? And then sometimes, again, I always think when I call the attendings at UK and I'm like, I could probably manage this patient here. She's probably fine. But then you think, but if she's not?
What if she's not? And that was my...
And I can get her out now. And tomorrow the weather may not be good if she crashes. The saddest part sometimes is like you will deliver them prematurely. Like, I've delivered 27-week twins, can't help it. They're coming. Like I can deliver 27-week twins. That's not the hard part. That's the easy part. Like, just do the section, get them out. Like, easier actually than 38-week twins because, they're small, they're tiny. Just gently go them out. But the thing is when they come out, right, we don't have a NICU. We don't have a neonatologist. We don't even have a neonatal nurse practitioner.
Are you doing resuscitations?
No, our nurses are NRP trained, and they will do it, and they will stabilize these babies. But again, then the babies are gone, and the mother is, fresh C-section. She can't leave. Like, I have to watch her, at least 24 hours before I can let her go, and then she can't see her babies, and then they're just depressed. That's depressing. I'm stuck in this hospital. My children are in a NICU 2 to 3 hours away. I can't see them. I can't hold them. I can't check on them. I'm stuck here. It's heartbreaking.
So our kids are born premature in Chicago.
Yeah.
They actually wheeled my wife's bed. We had preemie twins. They wheeled her bed into the NICU.
Yeah.
To do kangaroo care.
Yep.
The day of her C-section. Incredible. We were lucky. We were apprentice.
My patients don't get to do that.
But yeah, I mean, the number of things that we just don't even consider because it's not in front of us, because we don't experience it.
Right.
And again, these stories that, from my experience, but also your experience is so much broader and deeper than just the little tiny window I got into caring for folks in Eastern Kentucky. I was like, I just have to bring you on to talk about this, but it is incredible. But one more question about the lowest life expectancy in the country. I looked at the numbers recently. I've heard as many as 6 of the bottom 10 counties. It may be more like 4 are in Eastern Kentucky, maybe 6 if you include West Virginia, but in terms of Appalachian. A lot of that is due to the opiate epidemic, is due to young people dying. And, you drive down there and you see pain clinics everywhere. How much of that is impacting your practice still today? I know we've read a lot about this on the news, and there's been more and more awareness of the opiate epidemic, but how big a problem is that right now still in Eastern Kentucky?
It's huge. It's huge. I don't know if it's ever going to end. It just feels some days like it's not. It's changed, I think, with MAT, doing Subutex and Suboxone, and having clinics that are doing this therapy for the patients. It has helped tremendously. I have seen less hepatitis C. Seems like I've seen less hepatitis.
Well, thank God it's treatable now, right? I mean, that's the other thing is...
Yeah, right. It's treatable. And also, I think a lot of patients are getting care through, again, MAT therapy. And so that's helping them stay.
MAT stands for?
It's maintenance addiction therapy. I'm trying to remember. I say MAT, but it's Subutex, Suboxone.
Do you have your X license or whatever?
I don't. There is an OBGYN partner of mine who has her license and plans to start back doing it. I plan to get my license, actually. So this is a whole other conversation, but the clinic that I was working at up until this past month would not allow us to do it. They did not want to get involved in that.
Interesting.
But my new clinic that I'm working at, my new employer, does have already physicians and psychiatrists that do prescribe it. They have a whole setup with therapists, and they're very well connected with the treatment, and therefore I would be able to get my license, prescribe it to my expecting mothers, and get them connected to resources for full scope care and therapy. Thanks to University of Kentucky, with our wonderful Blue Angels program, we have telemedicine with the maternal fetal medicine specialist. And Dr. Henson, who is amazing, has also started up a new program where we're going to get these mothers enrolled into like group therapy. And she's got this whole other, program where they're...
But it's incredible work.
Yeah. Is it a solution? Well, I mean, it's certainly the right direction, and it's already leaps and bounds, I think, better than it used to be. When I first came to Eastern Kentucky, there were days it just felt like every other patient was hepatitis C positive, and their drug screens, as we would say, lit up the Christmas tree and, positive for all this stuff. And yes, I still get those patients. I still get the patients dropping in with no prenatal care who, is not actively seeking treatment or help. Yes, we do have babies who are what we call NAS babies, neonatal abstinence syndrome babies, who are going through withdrawal. It feels like the far majority are Subutex. These mothers are seeking treatment and help, and therefore they're in the process of being able to take care of their children and keep custody of their children and be the parent that...
There are far more resources than there used to be, and not enough.
Yes, not enough. We need more. We need more resources. We need more help. And I was just thinking, as you were talking earlier, and you were, saying all the nice things about me, and I appreciate it so much. I thought, oh my God, if somebody hears this podcast, they're going to say, oh my God, I'm never going to want to practice in rural America. That sounds scary.
Well, so my next question was, like you said, I don't want to make it all doom and gloom, but
no, because
one of my questions is what are the biggest rewards, right? Because you wouldn't be there if it was all bad. And so what are the things besides, having family around? Actually, you know what? I'm going to take a step back, because it's not just family. And one of the things that I've also tried to learn more about is what home means in Eastern Kentucky and Appalachia, because, my parents aren't from Kentucky. They moved to Lexington. My brothers moved away, whatever. It's no big deal. But there's something about growing up in communities like those that are there in Eastern Kentucky where the culture is strong and the roots are deep. To get up and leave and go somewhere else is not so simple as just hopping in your car and loading up the truck and moving away. I mean, the cultural connections there and the familial connections there are extremely strong in many cases.
Well, I think what I try to remind myself on days that it's hard and days that I have been, I was saying it's humbling. Can I handle this? And you have self-doubt those hard days. And I think, oh, I'm an idiot for doing this. And what I have come to realize is someone needs to take care of these patients. And not just me, more OBGYNs need to be here. We need more resources, right? And if I say, I'm just going to go somewhere where it's just easier and, what happens to these people? They're going to still be here. They're going to still have babies. They're still going to come in through the ER. And there's 2 hospitals that are one is in the county just north of where I am. They used to do OBGYN. They had 3 OBGYN docs, and over the years they've retired and one moved away. They haven't delivered a baby there in probably 8 years. The poor ER doctor is calling me all the time. Got this patient here. She's in active labor. They brought her here. Why did they bring her there? They'll just go to the nearest hospital. There's so many hospitals around me that have no OBGYN care at all. It's literally a Band-Aid dispensing center. It's an ER. That's it. In a 20-bed, basically sniff unit for elderly. And they keep coming in, with obstetrical complaints. And they don't even have an ultrasound tech to scan these patients, to even get a heartbeat or anything. So anyway, point being, what is the reward? The reward is, if I was in Lexington, I would just be one of many OBGYNs taking care of patients. And I could be replaced by X, Y, and Z doctor, whoever. It doesn't matter, right? Here, I have such a big impact, because if it's not me, then who? I'm one of 4 doctors who cover this hospital. That's it.
And you say, I need to take care of these people. And the truth is, you don't, right? And that's why a lot of these communities are going away. And you're providing a service that these patients are so fortunate to have. Because if you go, there may not be, like, if I leave zero concerns that they will hire someone to replace
They
me.
will hire another mixed guy, right?
They will hire another mixed person. But I don't think for a second that I'm irreplaceable. But I do believe that, and I've seen it. I've seen, UK's managed practices in Hazard. We have other rural practices. It is harder to hire into those practices than it is in the practice here in Lexington. If not you, then the answer may be nobody.
Right.
And that's a scary
That's a scary thought. That's terrifying. And I don't like that. And again, it is personal for me. So again, it is very personal. So it's hard for me to give an answer that's not personal. Like, it's hard for me to say, because I do feel like these are my people. Like, these are they always make fun of me because, like, the nurses are like, are you kin to her? Are you kin to her? Did you go to school with? Because everybody I'm either like related to or I went to high school.
And for those listening, are you kin to her means are you related to her? There's a little bit of Eastern Kentucky translation. I moved back home, and there were people from Eastern Kentucky who you would say, "Hey, do you want to do this?" And they would say, "Oh, I don't care to."
I don't care.
And you're like, does that mean you want to or you don't want to? Like, oh, no, I don't care to. I'm like, I don't know what that means. That means I don't mind. Like, I don't care. But I don't care to sounds like I don't want to do it.
No, it's actually the opposite. They'd like to.
I don't
They'd
care.
be fine. Yeah, I don't care to.
I don't care to. Yeah, it's fine. Yeah, I don't care to. That sounds great. I'm like, wait, what?
We also like to put random prepositions on everything. Like, whenever I was doing my general surgery rotation intern year, and the general surgeon made so much fun of me because I said, that patient, she kept crying on me and crying on me. He's like, she cried on you. Yeah, on you. Yeah, well, no, not on me. Well, that's what you said. I'm like,
A little bit of a language barrier, no, for sure.
in reality, I love home, and I love the mountains, and I love these people, my people. But I care about it, and will I be here forever and ever? I have no plans of leaving, but sometimes you think, I can't do this anymore.
Hard days are hard down there is what I'm hearing.
And I'm sure you don't, it's not like you have easy days in Lexington. I mean, you got hard days there too. It's just a different kind of hard.
I don't have days in Lexington like I had down in Hazard. I'll say that. And
Don't tell me that.
the next thing to talk about is how to fix the problem. And not that we're going to come up with an answer today, but you mentioned the Blue Angels program, which is an incredible program that our MFMs here at UK, they have telemedicine. We have ultrasonographers going out to the community, and we have our high-risk OB docs talking to patients throughout their pregnancies, which is really important for the less acute care opportunities. But I think about, technology and telemedicine being one of the big solutions, and we're starting to look at that for gynecology, because a lot of what I do, a lot of the visits, a lot of the conversations, a lot of the testing can be done remotely. I can get ultrasounds or MRIs at local hospitals and get the images up, and I can have them come up for many cases just for the surgery, or if they're getting a fibroid embolization or something, just come up for the case. You can do an EMB, you can do a PAP. But the pipeline to making more doctors has to, I think, include people from a diverse background of communities, because it means they'll be more likely to go back and take care of the people that they grew up with. I mean, look, we're both living in the towns we grew up in and working at hospitals down the street from where we were born or where we were born. And I'm not even my parents aren't even from here, so I don't have these deep Kentucky roots or anything. But I certainly was more likely to take UK more seriously, and I was able to call my chair and say, hey, remember me from med school, and, to get a job. And so by allowing more and more kids from these communities into med school, and that's where schools like Pikeville are in that part of the state that can put more and more kids through the medical school training, will increase the number of people we have back in those communities. And I think that has to happen. We got to have more rural residencies now. We're seeing some of those too, right? I read there's one in Wisconsin.
I would like to see some resident, and I don't know how you could do it, keep the numbers and the volume up, but it would be nice if they did a rural health month or a few weeks, and just send me a UK resident down here in OBGYN and put them in the clinic and let them see what we deal with, and put them on a few nights of call and let them deal with it. I think it would give them appreciation for it, because I'm sure they're rounding on our patients the next day like, this is that patient from Prestonsburg.
No, I think we all did that, and you're not trying to be a jerk about it.
No.
What were they thinking, or why would they do these things? But I think a rural rotation would be extremely valuable, extremely eye-opening.
I think it should be a requirement.
I rotated at a smaller hospital in Chicago, and we were the only doctors in-house. The attendings would come in for deliveries, and that felt like, oh man, we're so alone. But there was ER docs, there was anesthesia there. We weren't really, at all alone, but it was very, very different. Again, we can tell your stories, and I can tell my stories. And when we see each other next time at a conference, we can, ignore HIPAA and be more specific, because there aren't other people listening. But until you go there and experience this, and this is how a lot of America lives, right? This is not one small window into a very unique community either. That's the other thing, is we're talking about Appalachia, but a lot of the West, right, Alaska and huge swaths of this country are extremely rural. And, we're talking about 2 hours from Lexington. There are places where you have to fly, right? Understanding rural communities, understanding what doctors in those communities have to do will allow us to help support more resources for those communities, whether it's resources in education and medical schools to produce more kids, whether it's paying docs more to go out there or whatever it is. I mean, obviously it's a really complex problem, and I know there's people working on it, but it is something that I really want people to understand a little bit better after hearing this, because it's something that truly, I'm from Kentucky and I had no idea that this is how things were how medicine was being practiced, how things were going just, an hour or two away from where I live.
Yeah. It's so funny. I get all these constant emails and texts and phone calls from all these different companies. Hey, Dr. Branham, we're looking for some locums work, blah, blah, blah. And they're always trying to hire me to go work some locums job. And every time my response is, no, it's the opposite. Can you send someone here? I'm tired. I don't want to work for you.
Oh, God, that's so funny.
I'm like, no.
Actually, can you send one of them down here?
No, you can't pay me what it would be worth to me.
Oh, that's so funny.
I think this is the other scary part, right? Graduate medical education for OBGYN, we have a certain piece of that pie. We're not getting any bigger piece of that pie. The numbers are what they are. And there's a national shortage everywhere, not just rural areas, for our profession.
It's got to change at the national level, the federal level.
I could go to Louisville and get a job today. I could go to Ashland and get a job today. They are calling me all the time, wanting me to come there and do shifts. And this is in urban areas. How in the heck am I going to get somebody down here if they can't even get them up there where they have an airport down the road? And I've got an airport 2 to 3 hour drive. It's scary. And I don't know the solution. And I don't know if there's any. Feels like if you talk to ACOG about expansion for our profession, it's nope, can't happen. Sorry. Government's not giving us any more.
Well, it's a big problem,
yep.
But I think a big problem takes a big solution. It's not one thing, right? It's a series of things that we've touched upon. The areas that have the least resources are the ones that likely need the most resources, and we need to really think about how we direct those resources. And I really give a lot of credit to, you mentioned Dr. John O'Brien and Dr. Wendy Hinson, who are our MFM, 2 of our MFMs here at UK, who have really worked incredibly hard to try and serve the communities outside of Lexington, especially in Eastern Kentucky, and think creatively and think strategically in how to care for patients outside of that community. And it's been very inspirational to see that too, and that relationship and how the bigger health centers work with the smaller hospitals. And we're not in the same hospital network, right?
No.
We could be seen as competitors, but
no.
Putting patients first, putting our physician colleagues first, and working to try to build better relationships, better programs to try and minimize the complications, try to improve the care. And that's part of the the fibro program we've talked about on the show and that we've talked about, you and I. As much as you can do ahead of time, they could just come up right for the UFE if we had all the information. So how do we minimize the travel? How do we make it more of a one-stop shop? Because it's tough out there, and it's tougher out there for some of these folks in real rural communities. And I just wanted to make sure people had an opportunity to hear from you, to hear from someone who's out there doing it, who's doing incredibly important work, who's doing incredibly difficult work, in hopes that more people can hear about this and we can have people try to think about creative solutions or can put some pressure on those national organizations that can have an impact, because the problem's not getting better, right? We're chatting numbers and it looks worse today than it did.
It's bleak.
Yeah.
It's so funny. I was sitting there thinking, we could talk for hours about all the multifaceted. It's a very complex issue, and just not OBGYN, but medicine in general, medicine,
right?
People, taking care of people.
It is. But, I think hearing your story, hearing your experience, hearing, what you do and the challenges that you face, even just a tiny window into what you do, I think is something that many of us never get a chance to experience. But I think we can all agree what you do is essential healthcare for this community, for this country, for your patients. I'm very grateful for all that you do. I'm very grateful that you were able to join us today on Back Table OBGYN. And you were one of the first people I thought of when the show doesn't even come out till later this week. But, you were one of the first people I thought of that I thought, what, I think this is an important story to tell. And so
thank you.
I know you're busy, as we talked about. I know your time's very valuable, but I'm very grateful that you were able to come on, and I wish you all the best. And I look forward to seeing you again at a meeting sometime soon, or next time you're in Lexington, give me a call and we can hang out.
Will do.
Awesome. Well, thanks so much, Dr. Jessica Branham. I hope to have you back at some time soon.
Anytime.